you're having a good day so far and that you're in the right session. This is billed as Kent and Medway Listens, though actually we've extended a bit beyond that since the programme was first printed. So, Kent and Medway Listens was the largest and deepest county-wide engagement exercise ever undertaken, focusing on the mental wellbeing of the population. It was a huge project, which you're going to hear more about shortly. We're going to be hearing from Farah Virani, who was involved in running the project and who's going to discuss the outcomes and the lessons learned from it. This is very much a session that's focusing on process, different ways of doing things and lessons learned, rather than anything kind of formal and setting out a map exactly for the future. We were talking beforehand about how nicely the keynote set out this sense of individual action and ability to make change in the world. We'll then hear from Edyta McCallum, who is the Research, Innovation and Improvement Senior Programme Lead at Kent County Council, who is picking up where Farah left off in some ways and at very early stages of that project. And then Susan McPherson, who is Professor of Psychology and Sociology in the School of Health and Social Care at the University of Essex, is going to talk a bit more about the wider and more general challenges of building mental health research capacity within the region. So we're going to hear from each of the speakers in turn and then have questions afterwards, so there's a bit more chance for discussion. And you're okay to kick off?
Yeah,
Brilliant.
Sounds great. Thank you for the introduction. So good afternoon, everybody. My name is Farah, and I'm very excited to be talking to you all about the project that I was involved in as a Darcy Fellow. So, introducing Kent and Medway Listens. So, this project was carried out to understand pressures impacting mental well-being of the local population and to look at ways to actually relieve those pressures that we heard about. And as we all know, there are a myriad of factors that impact mental well-being, but the Office of National Statistics stated that COVID-19 caused a national decrease in mental well-being indicators. Wider socio-economic determinants of health disparities are implicit in poor mental well-being, and communities subjected to unfavourable circumstances were disproportionately impacted. And this is reflected in the Kent and Medway negative correlation between the index of multiple deprivation and the well-being index. And those exposed to health inequalities are more likely to have a reduced personal resilience and therefore more likely to have reduced mental well-being. And community members affected by health inequalities are less likely to be able to access care and therefore seldom heard by health or social care services. And there was a desire from the public health partners across the county, so Kent and Medway Partnership Trust, NHS Kent and Medway Councils, to commission the work in this area. So Kent and Medway Listens, as mentioned, is the largest ever engagement project across the county in relation to mental well-being, which utilised a range of voluntary sector organisations to reach into local communities and hear the voices of individuals from a wide variety of backgrounds. The aim was to hear the voices from community members who were unlikely to be known to any services or in relation to their mental well-being, and to provide some quick wins through decentralised funding and being able to co-create solutions to combat the pressures identified and provide this intel to decision makers within the system. So I'd like to introduce all the main characters and the supporting acts. So without whom this project would never have been able to be possible in the first place. I know it's a really busy slide, but I really want to highlight how many bodies and teams were involved in making this happen. And the star of the show truly were the voluntary care sector partners we worked with. And I will discuss this in more detail as we go. So, after engaging with 5,332 community members, it was no surprise that mental well-being was impacted by factors such as COVID uncertainties, employment uncertainties, and cost of living. However, when we explored ways in which to relieve those pressures, local community members wanted more support to feel mentally and physically healthy, but more importantly, they wanted more local support within their communities. And when you take a look at what they actually requested, it's really similar to what we look at in terms of Maslow's hierarchy of needs. It really puts this into perspective. Local communities are asking for very basic psychological and self-fulfillment needs, which we all deserve to have. So, moving on to accountability and devising solutions. So to try and relieve some of those pressures for community members, the voluntary care sector partners who carried out the engagement work were given a total of £100,000 of decentralised funding. This is no strings attached funding. I'm making that big statement there. That was split up across 4 of the HCP areas within Kent and Medway and Swale, and they co-created a total of 50 wellbeing projects and the funding was used for things like life skills programs for those with temporary accommodation, funding for translation services, and even family-based activities for refugees who are feeling isolated. All project updates were fed into the Better Mental Health Network, and this grew and enabled cross-pollination of work, new learnings, and project accountability to be held. And the network has remained open to anyone with an interest in mental well-being in Kent and Medway. So once we had gathered all the intel from the engagement work and well-being projects, this information was fed back to stakeholders in reflection and action planning workshops, in which pledges, possible solutions, and pressures impacting mental well-being were focused on. The quote that really stood out for me from these sessions is by the ICB chair here on the screen, and I'm just going to take a little section of it. He says, "On behalf of the Integrated Care Board, there is a rock-solid commitment to be part of the solution and part of the journey." So, moving on to successes, lessons learnt, and unexpected outcomes. And I know this is the juicy section for you all, so I'm going to try and lean into it a little bit more. So I wear a lot of hats. I come from an NHS background. This particular piece of work obviously sits within the Council and the Public Health Forum, but I also have a Darcy Fellow hat on in terms of systems thinking, blue sky thinking. So I'm going to discuss a few elements and maybe make some controversial comments as we go. So, as mentioned earlier, the engagement work was done across 4 HCP areas of Kent and Medway through the voluntary care sector partnerships, and it was felt that the pre-existing relationships within the communities would be able to identify community members that were seldom heard. And this did bring an element of bias and possible tokenism to the project in some extent. It was very noticeable that the VCS partners that had good relationships within different communities were able to employ collaborative dialogue, use an asset-based approach by empowering listening champions and local community members, and using a time banking tool, engagement tool, to exponentially increase engagement within communities. However, many community members were initially very hostile to the project and distrusting due to previous broken promises and no previous evidence of change. And to combat and rebuild rapports, we had the support and advice from my Darcy Fellowship faculty members and community organising training from Citizens UK, who was a supplier that was helping us with the engagement work. They had previously carried out a similar piece of work called South London Listens, and they shared all their learnings, their tips and tricks with us. Furthermore, the decentralised funding was definitely a strong tool to build local relationships as communities could feel listened to and see the project work take place from what they had shared. Many projects were co-designed or co-created with community members. It gave them a sense of shared ownership, received direct benefits from the experience, and built social capital within their communities. However, the full ladder of co-production was not feasible, and especially not feasible continuously, due to either time restraints or simply because of systemic issues with no real quick fixes. And finally, evaluation, always a cornerstone in some of these projects. This was a difficult area as thousands of quotes, stories, feelings were collected, and it's really important to understand the human side of this project. But trying to formulate qualitative data in a pretty picture to represent mental well-being proved rather difficult, as you can see. We had not considered requesting additional support or analysis or a robust structure to evaluate the mental well-being projects because we didn't know what they were going to produce, especially because it was no strings attached funding. However, the Better Mental Health Network has been proven to be a place of truly building new relationships and learning from one another, and this has definitely been a really good element to it. So, finally, what does this mean? So, outcomes and next steps. Regarding outcomes, there's been an increase in knowledge and cohesiveness about community needs. evidence of co-creation, of grassroots wellbeing projects, and individual changes in mental wellbeing. The insights of this work has been fed into the Kent and Medway Joint Needs Assessment, and recommendations have been submitted to the Cabinet briefing papers. Kent County Council will be hosting the next iteration of listening events to produce the public health strategy, and a new pot of decentralised funding has already been implemented for future mental wellbeing projects and initiatives. And this work hopes to continue to build upon community and voluntary sector partner relationships. This is truly an opportunity to change the way systems act rather than react. And I have seen that enabling community members to be equal partners through the engagement work can truly catalyse this process. So thank you for listening, and if you are interested to find out more about Kent and Medway Listens, feel free to take a look at this link. The QR code is on the screen, and I'll be happy to take questions at the panel discussion.
Thank you. So we're now going to hear from Edyta McCallum, who, as I mentioned, is the Research, Innovation and Improvement Senior Programme Lead at Kent County Council, and she's going to talk a bit about what Kent County Council is doing now in terms of developing a joint health and wellbeing strategy, partly building from that project, but this is very, very early days.
Thank you very much. Thank you for the introduction. Thank you for inviting me. So yes, I haven't even formally started in the post, but I'm very excited about it. And I'm very privileged to come here and give you an outlook of what it will involve. So just a bit of background. So I work as a head of research and innovation in Medway NHS Foundation Trust. And back in 2006, the National Institute for Health Research, they started supporting acute trust in developing the research and development offices. The purpose being bring research to NHS, because obviously it provides best treatment for the patients in terms of novel medication, access to medication which often would be very expensive from pharma companies. So I started in 2009, and starting with a completely they're just two people, very little funding. With 13 years later, we've got a team of 30, large income funding streams, and a very successful research office that serves our community and enables them to have access to all those wonderful treatments that they probably wouldn't have if the research offices didn't exist. And the primary example is COVID. Effectively, when the COVID came, we already had established research offices, so we could bring the novel medication, vaccines, and serve our public and help fighting this pandemic. So there was actually our moment to put us on the map. For many years, I always considered importance that when we look at patients, we shouldn't just look at the patients, because it's very easy to look at just one organization. So acute hospital, we just treat our patients in the hospital. But effectively, the journey of this patient starts in the community or ends up in the community as well. And also, so I've always seen the benefit in working with other organizations, so acute care, with primary care, with mental health, because we should be looking at the whole context, the whole concept of health. There was one element. Another element that I'm academic by background, and I see a great benefit in academics working together with medics. And through my role in London as well, I've seen that both have a lot to contribute from academia. Being able to articulate the ideas that the staff, not only consultants but staff in general, bring forward, and then the medical staff also bringing the practicalities to some of the ideas that academics bring. It marries beautifully together. So I've kind of started in Kent and Medway, establishing this just joint research collaborative where I brought all those parties together, and there was lots of enthusiasm. And it still continues. In the meantime, through that network, I also brought Kent County Council and we've got Medway County Council to the table, because I said to them, we should be doing a lot of research. It's great for us, you've got all of us here together, but now we have to decide what projects we're going to serve our local communities. What are those priorities? What are those problems, and what shall we prioritize? We all intuitively also think, that there is, my idea is the best to solve something, but is it really? Maybe we should start looking into it and provide evidence. So then I was approached by Kent County Council recently for this secondment. So it's an opportunity for me to bring these learnings from while learning the acute trust in those networks to the Kent County Council, to the public health and social care, mental health, to see how we can work together. So that's a kind of a background. Now, the Kent County Council, actually, hats off to them. They've done some work with University of Kent in 2020, actually, where they went. They actually issued surveys and they had some workshops and conversations with the public health consultants at the time to find out, is there appetite? What are your obstacles? Why aren't you doing any research? And when I say research, we should never forget that there is within research, there is service evaluation, there is audit, there's quality improvement. So sometimes actually in terms of the terminology, when we say research to local authorities, they probably get scared because they think, okay, you're going to test medication on someone and how are we going to deal with governance and everything. But if you say improvement of something, that's a little bit, softer, it's good. So that's what were the suggestions. They said that based on this outcome of that investigation that the University of Kent did, they said, I think we need research and innovation function, and that's what they could be doing. So that was kind of a summary at the time. And again, now they kind of brought me to help to set it up. It's a difficult job because it's a complete culture shift. There are packets of excellent research that they're doing, but it's kind of bringing it all together, making people realize they're actually doing great research too, and they should talk about it. So that happened in 2020. Now recently, everyone talks about the integrated care board, integrated care partnership systems. So I'm very very lucky that the Kent County Council has been asked to. Well, no, that's not Kent County Council. It's the whole partnership. The ICB have been asked to produce the integrated care strategy. And actually, the guidance literally just came up in July 22. For how to write it, and brilliant. There's a section on research. They actually, so it's very timely. So Kent County Council, they were planting the seed for a while, and here it comes. Now they actually have to commit to it. So yes, I'm very lucky. I've been asked to draft 2 pages initially of how we are going to do it. How is it going to work? Like I said, it's a major culture change, but they're very open to it. The partners include acute trust, and we've got R&D offices, so we can share our experiences already, and it's a case of linking the systems. There's a lot of discussion this morning about communication, and I think this is key, and bringing academics to the table, definitely 100%. And they are very very keen on it. So I think it's the times are changing a bit, and I definitely feel it at least in our part of the world. Now the strategy is completely being under development, and we've got deadline by next Friday. So there will not be time for any workshops at this stage. And I assume the Department of Health just want a brief draft. and then then we'll be able to get into more details of planning. So at the moment, we thought, okay, let's concentrate on 3 key areas, and we are working on it. We're going into more details. Probably by Friday will be much in depth. But you know, when I was writing it, what I found challenging actually is to how to articulate how, as researchers, I presume we've got a lot of researchers, how we can help to develop the systems. And so, you know, we all talk about wider determinants of health, and I think, you know, how could we help? But we've got access to all this global information. We know through research and evidence collection what probably is good, how to do things. You know, the networking again, massive international projects. We can learn from all of this. So that's one of them. And as I mentioned before, definitely we need to start looking at the whole patient journey, because again, there's lots of great work in silos, but we have to start looking at how one element, you know, system thinking, I think it's called, you know, how the whole system impacts the community and individuals. And then again, we were talking about it today a lot, about effective and efficient implementation. So there's a lot that has been implemented, but how do we know that it works? We were during lunch with someone that statistics, we produce statistics, but we can make statistics look good. Wouldn't it be good to have independent person, academic, coming in and actually kind of providing a feedback and positive criticism, if you like, you know, because and we need to learn to work together. So these are the 3 main ones at the moment, but obviously there's more into it, and I'm sure by next Friday there will be 50 more areas. Obviously one of the ones is governance. For those who, you know, governance is the GDPR and all kinds of areas that we have to look into. Someone mentioned this morning in terms of digital communication, how we do it, because we don't want to end up again working in silo. We have to learn how to share that information. So I'm very excited to be in that post. I will be working with wonderful people like Farah and other people who are doing the projects already. But hopefully we can work together and bring it, you know, I can connect Farah with other people in other areas, and there will be a place where we can all network and meet. So I think that's all I had time for. Okay, and there's my email address in case anyone would like to find out more or contribute. That would be fantastic.
Thank you. Finally, we have Professor Susan McPherson, who is going to talk a bit about the wider challenges about building mental health research capacity within a region. And Susan is unique here in that she's not involved in the Kent and Medway Listens project.
No. I'm an imposter. Yeah, we were just saying earlier, I was sort of a bit of a last minute squeezing me in, but it helped you, I think. So I not entirely an imposter, but I suppose that it's slightly different, because this is coming from an academic exercise and reaching out rather than the other way round. But I suppose it kind of links. I think there was the first question this morning was, you know, what can academics contribute? And I don't know if some of you were in the health session earlier, but there was also questions around, you know, how does the academic community contribute to the great work that people are doing in communities. So this particular program is coming from an academic context, but we're trying to reach out, and you know, maybe in the discussion we can talk about, you know, how that all links up really. So this programme is to do with the East of England Applied Research Consortium, which is a National Institute for Health Research funded programme. It's so each of the universities in the NIHR arc were given some funding. So at Essex we've got funding. We've got Daksha and David here who are from the Hearts, who are running their arm of this programme in Hertfordshire. But the arc, the other arc, not the Eastern arc, the East of England arc for NIHR is a 5-year programme, maybe extended, And like we've been talking about this morning, the idea is that there are all these partnerships with local organisations, trusts, and so on. But it's very much, from the research end out rather than the other way around. The particular programme was funded to develop research on mental health inequalities and to develop research capacity within the region around mental health, because it's traditionally been a region where not a great deal of mental health research has gone on relative to other regions. It was an additional block of funding which was applied for by the ARC in response, like this ARC, to the Chris Whitty report. So Chris Whitty report finding that there was an increase in suicide rates in coastal towns and other mental health inequalities noted in coastal areas. So in a way that's got the same birthplace, the Chris Whitty report, but it's specific to mental health. The components of the funding we've each got is slightly varied, but at Essex we have a postdoc and a PhD student. There are some clinical fellows in the region doing kind of research based in trusts. And David is the postdoc for Hearts, right? Postdoc for Essex isn't here because she's away, and our PhD student is also sick today and was meant to be here. But I'll tell you a bit about what they're doing. Our focus was, because we had, some of you might know, but at Essex we are the host for the Understanding Society dataset, which is based in our Institute for Social and Economic Research, which is a longitudinal household panel survey. And for a number of years, myself and the health team who work there have been thinking it'd be great to tap that data set for more mental health research, and we've been trying to find ways to do that, and then this money came along with a kind of an open slate really, and so we thought we would link those up and pursue that. So that's what we decided to focus on at Essex, was to use this data set and see what we could do with it to address the aims of the programme. So the collaborators are Mina Kumari and Cara Booker, who are based in Understanding Society, and another colleague here, Antonella Trotter. Claire Wicks is our postdoc, who's been managing stakeholder involvement, and she will follow through a project during her time. We have Alex Lewis joining us now to do a PhD, and her focus is going to be specifically looking at mental health in coastal towns. And what her plan is to think about, is to find a way to use Understanding Society, which has some quite detailed location variables, to try and look at what it is in coastal towns that makes them distinct in terms of mental health, and how that compares to coastal towns in the rest of the country, as well as non-coastal towns in the country. So to see if we can really build up a picture using a longitudinal household data set about what is it that might be leading to a crisis of mental health in coastal towns. Our timeline is that we had our first stakeholder meeting in June, and we've had a second one this week, so I can just update you on that. And we'll be working on this project till 2024, with a PhD studentship continuing on a bit. And we wanted to also use this opportunity to try and extend the programme. So in our stakeholder meetings, we have been trying to both generate input for what Claire will do as the postdoc, but also generate ideas for a new grant application, which is essentially something that our stakeholders want us to do, rather than us saying, we want to do this, what do you think? We've tried to make it the other way around. We want to apply for some money, what do you think we should apply for? Our initial stakeholder meeting, we kind of reached out to our networks, and we got a number of representatives coming from Essex County Council, Mind, Community 360, probably equivalent organisations to the ones in your brilliant map that you had of organisations, kind of equivalent voluntary sector, county council, and some public and patient members. We presented our aims, which were quite broad and quite different to, don't know about the rest of you, but to kind of reaching out. Normally I go to stakeholders and say, I want to do this, what do you think? Rather than doing that, we said, look, we want to use this data set. These are the broad aims, mental health inequalities. What do you think we should focus on? So we tried to really be much more open than I think academics normally are in these contexts. And we had a general discussion, and we came up with loads and loads of themes. As doing it that way, coming with all these themes, we couldn't possibly address all those themes. So there was a kind of a risk in kind of going so wide open, because we can't keep everyone happy. But what we were keen to do is to try and keep everyone happy somehow. And so what we did after the first stakeholder meeting was we reviewed all of the things that came up, and we thought, okay, there was one particular area that we could follow through using Understanding Society, but lots that we couldn't. And so we thought, how can we address all those other things in other ways? So what we did then was a couple of things came up where Claire could do some rapid reviews of evidence, because there already was some evidence, so we didn't have to redo it. So she wrote a couple of blogs, and we published those on the university website, and we sent them out to our stakeholders so that we could give them a quick review of the evidence on those things, volunteering and physical activity. There was concern about loneliness, so we knew that there was a team at Essex working on loneliness, and we connected those people with that team, so that now they've we've sort of planted stakeholders into an existing academic team. We also read a huge theme that kept coming up from our patient members was trauma and childhood abuse. And so I had a colleague who's an expert in childhood sexual abuse and trauma, who'd worked at the National Independent Inquiry on Child Sexual Abuse, who I got to come and do a presentation at our recent stakeholder meeting. So we tried to give back something on that topic, even though we wouldn't be pursuing it. And then we identified one theme which was really strongly coming out from a couple of stakeholders, which was around sensory impairment and its impact on mental health. And we decided we would try and follow that up to do a new grant application. So that's going to be another thread. And we wrote a newsletter covering all of these topics, and we're going to do a 6-monthly newsletter to try and round up things that our stakeholders are interested in and how we can help with those in terms of an academic input. And we keep the invitation open, so rather than having a fixed membership, we kind of keep inviting people to come along. Here's what we've done, here's our newsletter, please, you're still welcome to come and join in. Our priority theme that Claire will follow through in her analysis was primarily actually came from Essex County Council and their Joint Strategic Needs Assessment, which sounds a bit similar to some of the things going into your priority setting, but was had a key theme of wider social determinants, which I think you mentioned there. In particular, they're keen to look at protector characteristics and whether they vary in terms of mental health, which we can do with Understanding Society because it has data on all the protector characteristics and mental health variables and location. So we're going to be able to pull all that together and try and generate some research findings which we hope will help inform both Essex County Council's agenda, but it will also have relevance to all of the other organisations. I did have a, oh sorry, I turned it off now. There was a final, I don't need a slide, just to update you on our stakeholder meeting that we had this week. We went through all of those things, and a kind of a different but overlapping group of stakeholders attended, and we ran through all the things that we'd been doing in between, and we had another discussion, and again, interestingly, trauma came up and up and up again, even though we still can't follow it. But I suppose the challenge, really, the big challenge is how do we keep all of our stakeholders interested and engaged, and how can we give something back to our stakeholders when we can't answer every question through research. So I suppose that's trauma being a good example, really, is it's a really important issue in mental health, and it's a massive risk factor, but it's not something that's easy to look at with research, especially child sexual abuse. And there's different types of research which might be able to address that better. So I suppose the challenge is how do we as academics know what all of our colleagues are doing so that we can link up stakeholders who come to us who maybe don't fit with the project we're doing, but we can link them up somewhere else. So some of that is about knowing all our colleagues, which I don't think we're very good at, is it? Kind of knowing what we're all doing in the university is not always something we're good at. So another thing I've done in between, last point, is to actually set up a survey for all of the academics in Essex to tell me what they're doing in mental health research, so we can kind of keep a resource so that we can link people up with people that I don't know about. So it's great because I'm finding out loads of things that I didn't know about my own colleagues. Okay, I think that's it.
Thank you.
Okay.
Okay, we're going to have a kind of question/panel discussion so we could hear from people that I'm just going to move the chairs over a bit because most people are on this side of the room. But if anybody wants to kick off with a question for any individual speaker or the whole panel, yeah.
Thank you. Really enjoyed that, honestly. Thank you very much. Farah, about you engaging with communities, were you able to capture ethnically diverse communities?
Yes, so we did record, and the way we did record there was in terms of engagement. First of all, there was conversations that were had were one-to-one, some were virtual, some were in like house meetings, some were in group sessions, and we asked all the engagement and voluntary partners to not have like a tick list in terms of, you know, do you fit this particular category or this one. It wasn't set out like that. It was a request from the community member, and we found that over our data capturing, we found that we had 57 different ethnicities recorded over the course of these 5,300 something community members that we spoke to. So yes, but it was more of a case of a voluntary contribution from them. And that's what we ended up getting. The other, in terms of or not wanting to respond, there was quite a considerable amount. It was around the 20% mark that we were not able to capture, either because they didn't want to share, or that it was such a quick conversation we didn't get to that point in the conversation, either because it was busy or there was distrust or not wanting to engage in the project, whatever it may be. But there was definitely some elements of that too.
Yeah, I think where I'm coming from also is for what the messages you got in terms of concerns or barriers. I'm just trying to work out if there was anything different from those factors that came through from the ethnic communities.
Yeah.
And
So
whether that was built into the solutions.
Yeah. So there was definitely there was more elements of I guess discrimination and things like that coming through to some of the ethnic groups that we were listening to. There were elements. There was also lots of cross-referencing in terms of, you know, cost of living was a general concern. Employment was a general concern. So all the sort of the top 5 that I mentioned in the slide presentation were general concerns. When you get down to the nitty-gritty and you actually like pinpoint all those little smaller groups that were happy to engage and tell us, then yes, we were finding that there were more nuanced and very specific points that were being met. And just how you were all mentioning about sort of prioritizing,
yes.
It was really important. So I kind of keep saying I was a very respectful disruptor through this entire process, which is why there's lots of controversial things I mentioned. But through the process, it was really important, and I kept making this point throughout meetings, was just because we listened to one person in this one group doesn't mean that's anything. They're not invalid in comparison to listening to 50 people in the other ethnic group that we might have listened to. It does not, they're just as equivalent and just as important and just as valid. And it was really, really tough to tackle that area. But you're quite right. There was definitely nuances that came through.
I know there's a question back there, but I just thought that linked up nicely to Susan's point about trying to make sure everybody feels listened to. And I was thinking as you were talking about that, about the amount of resource that involves that's probably not in the original project and is essentially voluntary.
Yes.
Yeah.
Sorry, quite at the back. Thanks very much, Paul Mooney from University of Lincoln. So Farah, I loved your presentation. The value for money, starting with so many projects with so little money is just phenomenal. But I wanted to sort of touch on your last couple of bullet points around evaluation, and clearly a massive challenge. You could easily have spent your whole budget on evaluating one of those projects.
Yes.
And I'm just wondering, from what you've learned from the project, if you were starting again now, could you approach it in other ways? Reflecting on it, is the as academics, there's methodologies for evaluation, and they're very rigorous and detailed. This is all very expensive. Is that sort of rigorous academic approach to evaluation actually problematic, or are there sort of rapid, lighter touch things that you could be doing that would give you something back from all of your 50 projects, which you could then say, what works for who and where, and that sort of thing. So I mean, for any of the panelists to reflect on that, would be really interesting.
I'm happy to kick off and then you guys can feed in. So there's a couple of elements from that. So being a Darcy Fellow, I had LSBU basically feeding into the academic strand of this work. So in terms of evaluation, it was a very strong suit in their armour, but they were massive on co-production, which I loved, and this is what I wanted to employ. My first priority was co-production. My second was being academic, basically. So that was the first thing. The second thing is I got brought in as the project and all the grants and everything had been distributed. So I came in just as that was happening. So in terms of the actual terms of conditions and terms of reference on contracts, I didn't unfortunately have a say in that. Had there would have definitely been some changes that I would have wanted to make in that. And coming back to a point that was mentioned in some of the earlier morning sort of sessions that I attended, that I attended, was talking about sort of commissioning cycles, because that was also a barrier, the fact that you have to, put yourself up and, be competitive against other, similar bodies to be able to get that money, to be able to do the work that you want to do. In terms of rigor, yes, I think having a very rigorous process and being so academically thorough would have really thrown this project completely off course. Having the amazing goodwill of the voluntary sector partners coming in post-contract, being part of the stakeholder workshops after their contracted time, co-designing with me after hours, co-creating things with me after hours, bringing on listening champions, and us trying to scavenger hunt some extra money to try and pay the voluntary partners or the community members that were coming to these sessions was really difficult. So yes, so the budget would have been absolutely kind of distraught at that point. In terms of light touch, I would have preferred to have that. And again, I think having had that in the contract, maybe with the voluntary partners when they first signed up for the project, would have been great. However, it was decentralized funding. The whole point of decentralized funding was I did not have a say in the way that it got spent. The voluntary sector partners were in control of their money. I just needed the receipts. I needed to know that it was going to places that it was truly required. And I think that was really important to allow them to have ownership of their money, and not my money, not public health sector money, their money, to be able to help their communities. And I think that was the keystone behind this, and which is why the next iteration of funding has gone out. There are some changes and tweaks in terms of contracted, not because we've asked them to do anything different. We've still asked them to be engaged be as vivid with their sort of kind of creativity as they want, but to kind of report back to us and keep us updated in terms of quotes or how many people that might have attended a particular session. We got plenty of photos, which I tried to show in that really, really small little snippet there, but we've had amazing sessions where there's been like life skill, so people have attended like a wellbeing session and come out with like a leaflet or a session to go and have more skills in terms of getting employment. We had people that were helped to get their status from a refugee status to getting passports and things like that sorted out. There was loads of different elements that all these different activities and initiatives did bring in. Had I had a better way of capturing that, I think I'll be able to report a lot more back to you. But I think it's really important to walk that line and toe the line. I don't know what the right answer is, but I don't think academic rigor would have worked specifically in this case.
Do you want to chip in on evaluation?
I suppose with another hat on, I jointly run a health and care research service based at University of Essex, which offers evaluation services to kind of health and social care organisations, which is really interesting because I suppose that you're talking about funding, you're talking about how rigorous it is. We've been running that for maybe 4 or 5 years now, and we are learning a lot. Apart from offering the academic rigour to evaluation, we're learning a lot about how to respond to tenders really quickly, design an evaluation really quickly, adjust the rigour to the budget that the organisation has, and it's difficult, but actually we're kind of learning how to adapt those things so it can be rigorous and independent as well as responsive to what the organisation is actually doing. So it's tricky. It's not traditional academic work, but it's been interesting.
Yeah, I was going to say very similar. So I've mentioned that when we say research, it encompasses so many different methodologies, and that's why I think we have to be careful when we use just one terminology, which is research, because you've got quality improvements, which is different, audits, which is slightly different, evaluation. So So the way I see the function of the central offices is to actually help with the processes as your evaluation team probably does, is when the idea comes through to find out what's the best way of looking at it in terms of what methodology should be used. Is it important? I think it is, because there's a lot of work that's been done without any particular, for example, measuring outcomes. It's done based on qualitative analysis, so I think there's some needed, but definitely pragmatic approach, definitely, and as Farah mentioned, co-production, working with the patients and communities, definitely. I think it's more to be done. I mean, we all know when we submit research funding applications, we have to tick the box of patient-public involvement. But hand on heart, do we do it the way it should be done in the first place, or is it just a tick box? So I think there's a lot into it, yes. But I agree. We have to be careful not to overwhelm the non-research colleagues with terminology, methodology, and yes.
Okay, and then thank you, so I'm Nicola from Medway School of Pharmacy. A few years ago we did a similar community chest, etc. and grants project, and we involved the New Economics Foundation to do exactly that, to try and help us measure the inputs and get that qualitative as well as quantitative feedback. I have to say we struggled a lot, so I was with a clinical commissioning at the time, and at that time then our decision was we had to be brave and just go forward and trust in our patients, like you're saying. And the trouble is, with that amount of data, to then get something quantitative is nice, isn't it, and graphs. So we did look at the 5 steps to wellbeing and some other quantitative measures that we started using for that very reason, because it's about how you get funding, isn't it, as well. There's a game to play here a bit about how you manage to get that next pot of money. So the New Economics Foundation was quite helpful, and so social prescribing is another area where we were struggling to quantify that, but have a look there, it might help you.
Anything to comment on there?
Yeah, so social prescribers were amazing in this, and they definitely helped us out a lot with like the engagement work as well as work. They were like the links between the voluntary partners, communities, and us. So yeah, definitely. In terms of Darcy Fellowship, they have links with the NEF and Nesta as well. So that's kind of groups that I was working with. But having that scale as well, we didn't have any assigned budget. So it was me evaluating essentially all of this. In terms of, there were questionnaires sent out. There was whoever wanted to respond back in terms of, again, like you said, getting those quotes. I have quotes coming out of my ears, stories coming out of my ears, feelings that were shared coming out of my ears that I can definitely, give in terms of saying that, 50% said this or 60% said that, but I can't quite mock up to tell you that the wellbeing index quite shifted from here to here, because that's not exactly what I managed to do in a year. But the long-term outcome, so we've got census data that got plugged in along with the Kent and Medway Mental Wellbeing Index that also gets plugged in, and that joint data is going to basically be a 10-year kind of mock-up for the next census, and that's the plan, is that as this work continues, the idea is that hopefully this will have some impact, and therefore when we look at the next set of mental wellbeing indexes, that we can pull out some of those ideas and have kind of numerical data pieces, basically.
And then we have the lady with the lovely necklace. This is probably not Naomi's name. The gentleman there, and then after the lady at the back.
Thank you. Denise Waynes, I'm from the Public Health Team at Southend City Council. I have to remember that now. It was just, I suppose, a question following on, I think it was Dacia, when you mentioned about because you said, Farah, wasn't it, right at the very beginning, it's that seldom heard. And it was just, I was just thinking about when you went into this project, were the seldom heard already found, or did you reach out? Yeah, it was just looking at, because I know it's seldom heard.
It's a really interesting question that I actually get asked a lot, actually, funny enough. So in terms of seldom heard, when all the applications kind of went through for the voluntary sector partners who we were the main partners that we were going to agree to work with, and then they were going to filter out with other voluntary partners in the area, and depending on which HCP areas, they identified key groups that they felt that they were in touch with, and then from there, listening champions, so through time banking tools and actual engagement work in capturing those groups, they then went out in their communities. So it was a case of we managed to capture extra voices on the back of the engagement work that the community did for themselves. So I would have said I had a very blank slate. I was very open to ideas, and they came in with all the answers, basically. And I think that's the line that I keep saying is giving power and giving that kind of equal partnership to communities is such a massive tool in your belt that you can automatically do if you have the right people at the right table, basically.
I think here just that point about having an open slate and no strings funding and so on really makes such a difference in the various projects.
Thank you.
My name is Tassis. I'm a research fellow at the Institute of Public Health at the University of Essex. My question is directed at Farah, but the more general points that are in the panel. First of all, can I clarify? So you mentioned the funding, but I wasn't quite sure. So there was £100,000 pot divided equally to 4 centres. And was that 50 projects per centre or the entirety of the?
So there was 2 pots of money. So one was to pay the voluntary sector partners for working, essentially, and there was a second pot of money, the £100,000, which was the no strings attached money, and that was divided in 4. So 25, yeah, that is right, 25,000 amongst each HCP area, and they did what they wanted with those £25,000, basically.
And 50 projects.
50 projects came out of it. They weren't equal across the 4 areas. There's probably because some of the areas, again, in terms of the geography of Kent and Medway, there's more populated areas in particular, jurisdictions. In terms of, again, time, we had a COVID variant during that period of time as well. So it was different elements as to how many projects a particular area could give.
And that was their decision,
Yeah.
how many and how much to allocate.
Absolutely. Absolutely.
So I suppose the question: do you have a personal opinion on sort of funding more smaller projects? I realize you didn't have a personal input into the number, but do you have an opinion on a larger number of smaller projects versus a smaller number of larger projects, if that makes sense? I'll give you my personal motivation for this. So a few months back, I was part of a workshop which had a funding pot of £16,000 for projects, but they decided that 4 projects could come out of that, and we realized with the £4,000 allocated to the project we're proposing, there was barely enough money to hire a basic researcher and create a focus group which involved renting a room, paying for childcare commitments. So money for projects just tends to explode, and I'm wondering, does that, having smaller projects, limit the kind of outputs you can get from them? Do you have an opinion on what the right balance is?
So I'm going to give you a diplomatic answer, unfortunately. So there's 2 elements that because of the variety of projects that were created, I can't give you a yes or no answer, unfortunately. So some were like, there was an issue with, like, if I go back to one of the examples that I gave about translation services, for example, there was a Nepalese community, lovely bunch of people, very able to access services. You get to the service, but there's no translator available. Therefore, it's a knock-on effect on NHS sort of clinician time. It's a knock-on effect on whoever's transporting them to that sort of particular service. Lots of different other elements and lots of knock-on effects, essentially. But having funding for a couple of, I know it's a couple of months because it's, again, short-term cycles and commissioning, etc. Having that, though, just have that small kind of element makes a huge difference, but only for 4 months, so to speak. So in that kind of case, a larger sum of money would have been more beneficial. However, there have been projects, for example, getting communities to get together when they've been isolated post, I think it was the Christmas variant that we had, and getting them together. A very small amount of funding, I think it was £500, that got them through that. They created a walking group from that. They now network with other I think it's groups of like people with dogs and cats and different animals, and they go to different little animal shelters, and they've all made friends, and it's amazing. And £500 did that. So I can't give you a yes or no answer. It really is dependent on the activity that the project took place or the initiative that took place. It's dependent on the type of people that are in the group or what their needs are, and it's also dependent on the sustainability of what is required in a very, you know, in a social heavy and kind of activity. You just need people, you don't need funding. But if it's something like, you know, having funding for translation services, you need the funding to have that service in place. So a yes and no answer.
Do you know what's happening with the translator exactly?
So that's been taken up actually. I was privy to a ICB meeting, and that is definitely on their agenda to service that. And that particular group was in Folkestone, so I know that is happening.
Edyta and Susan, do you have any thoughts on that issue of the smaller versus bigger pots of money?
Such a huge question.
Yeah, maybe it's case by case.
I was going to say the same, absolutely, because obviously I oversee, there were 160 projects at the moment within one district hospital, so it's quite a lot. And in terms of resources, we cost each of them individually, and it will depend, because it also depends on the populations that you need to research, if you like, because you might be small in the first place. It might be in terms of access, if it's someone with needs, then they will need more funding. So I think you have to look at it from that point of view. And obviously, there's a lot to do around the design phase. But you know, I was going to also mention, we mentioned about economics and health economics. What we do in our acute hospitals and more in NHS is when we agree to take on research projects, we look at the feasibility of them being commissioned after they have been proven to be of benefit. That has become one of the top priorities, because there's no point in creating a project that we know that if it's going to cost council, let's say £1 million to implement, it's never going to happen. So we look at health economics in the projects as well before we approve them.
Thanks. Sorry.
Right, such lovely presentations, and I've got so many questions. So I'll try and get some of them have been addressed with the evaluation, etc. You sort of touched on this, but one that we also give out of money that we've described, and apart from the evaluation, you know, complexities and issues, and the other thing that bothers me slightly is the short-termism culture that creates, because obviously in terms of health and things that we want to target are long-term issues, and we're constantly sending out lots of little pots of money to lots of different people, and I appreciate, you know, for some projects a little bit, you know, one-off is enough, but for most it isn't. And I just wondered what your reflections on that were, and I'm going to spit out the other two questions before I forget. You can come back at me with what you like. Another one was around, more directed to the last presentation, about do you include kind of addiction as substance misuse in your mental health scope? Because I have major issues certainly in our area about the division of that in terms of service provision and unwillingness to appreciate overlap, and really fascinated by that research. Will you be feeding back the outcomes of that to local areas so we can use that in our work in terms of, you know, broadening what services we fund, etc. in the future? And I should have said, I'm sorry, I work for the North East Sussex, what used to be CCG and is now part of the CCG.
Sorry, what did you say that was?
Sorry?
What for? Sorry.
What used to be the North East Sussex CCG, so it's now the Suffolk and North East Sussex ICB.
So what's it called now?
ICB.
Okay, so the first question was about reflecting on short-termism in funding and the effects it has. So, small question.
I have lots of opinions on that. So that was a massive problem we brought to the table, and it was the first thing actually all the voluntary partners sunk their teeth into actually when it came to the ICB chair, so bless him. But he actually has agreed to take that to the rest of the board And that was the last stakeholder meeting that I was present for, which is only a couple of weeks ago. And that is actually is supposed to be part of now the public health strategy in terms of looking at the next iteration of listening, and also looking at the way things are commissioned, that it doesn't need to be short cycles. And you're quite right, there are different projects where, like I've mentioned, that it's not service heavy, it's social heavy, and therefore, short bursts are absolutely fine. You just need to get the people to make the networks and then they're good to go. However, when it's service heavy and we're talking about wider terms of health, that is not a quick fix at all. And the initiative that I was talking about in terms of the next pot of money to be ready, again, is not looking at fixing any of these systemic big problems. It's looking at building those rapports and continuing that sort of network building that we have with the communities. In respects to the ICB chair, the conversation that we did have at the last stakeholder workshop was that he listened to all the voluntary care sector partners all complain about the commissioning, the going through the grant processes, the competitiveness. But had this project not happened, we would not have a listening champion, a voluntary care sector partner, and an ICB chair member all sitting together in a virtual meeting, I'll give it that, but sitting together and actually being able to talk. When does that actually happen? So the fact that that conversation has taken place, I'm quite excited to see what you're coming up with next. So I'll tag it back onto you.
So we're definitely it's in the under development. So hopefully it's been listened to.
Yeah, it's been listened to. I'll put that much.
Susan, do you have?
I just think it's a much bigger question, isn't it, about how health and mental health are in the kind of political culture of although there's like people in the our level who are doing the work on the ground, either in the community or in academic, that it's still ultimately politicians who dictate the budgets, and they are on a short-term life. So I think we're just living in that I don't know what to do about that really, but I think that dictates the way that funding is always short-term for health at a big scale or a small scale really, and I suppose led by short-term outcomes.
There's always this desire for transformative effects when what you're really doing a lot of the time is trying to chip away at improving people's lives, and that's difficult to sell, even though it is so important. The second and third questions were, are you tackling addictive substance issues as part of the project, and are you going to feed back outcomes into local areas?
Was that for me?
Yeah.
I mean, I think as I hope came across, is actually we threw it open to our stakeholders. So actually, whether I thought it should or shouldn't be included, it wasn't going to be up to me. So I mean, personally, especially I suppose in luxury of an academic, I don't see the distinction, because we don't have to work in those sorts of silos where addiction is dealt with that service and depression is dealt. So to me, it's all part of the same thing, and as a psychologist, to me, it's all part of the big picture. But I suppose, so that would have been open. In fact, no one did bring up, I think it has come up. It's come up in the Essex County Council strategy that addiction is an issue. So we will include it. Yeah, there's no barrier from our perspective to looking at that. Will we feed it back? Yeah, absolutely. So we have built into our time plan the dissemination, because for us it was an almost unheard of open pot of money to do mental health research, and we wanted to have stakeholders driving it. So we built in time at the beginning and the end for that, rather than the research takes up 12 months and the planning and the dissemination is either side of that with no funding. That wasn't how we planned it. So yeah, that is the intention.
Can I ask one more question? Sorry. Just the other thing that intrigues me about all the things you're doing is, how do we utilise this in kind of emerging models of PHM?
What was the last bit? Sorry.
Population health management. Everybody thinks of it as just the hard data, sausage and this and that, the other, but actually bringing in the qualitative data is just as important, and putting them both together to inform our interventions, etc. So is that conversations being had in the research world? Are you informing that process?
Yes. So in terms of the data, it's it's happening. Within Kent and Medway, there is already a research database established that especially University of Kent at the moment has access to, and that encompasses all of the primary care GPs, including believe police and some other public health services. The thing is that it's old data, if you like, because of the GDPR issues. That's the biggest problem with the general data management, if you like. So now they are working on agreements for the new data, if you like. But if you can imagine that this ICB is well, we'll see what they come up with, because effectively the problem is that acute trust data belong to acute trust and even between themselves, and with all the GDPR laws that came out, it's, so to be honest with you, hats off to them. They've been working on it. They've got a group set up. 5 years. The fact that they've managed the organizations to allow access to the old data is amazing, I think. So I think they're basing it, the access you provide, the organizations can object to the project, so it's automatic approval that will base on an objection, if you see. So they're trying to do it the other way around, because otherwise, if you went through all the IG officers in all the partners, so they are working on it because it's essential. Effectively, what we need is to work on data, link it all together. It's all there. But yeah, the GDPR thing to address some issues but cause other issues, and for research as well. I mean, we had a nice time period when we could use some of the data because of COVID, but now since August, I think it's back to the stricter rules. For us, the biggest problem is if any of us object to having the data included, now we have to find it and withdraw it from any releases to anyone. So yeah, so it's difficult. So, but yes, they're working on it.
Any thoughts on data? Qualitative data for population health management?
I suppose I was thinking from a wider perspective, like how does not so much data, but how does research evidence feed back into policy making? And I suppose in health, very, very narrowly defined, there's this idea that, you know, we review evidence, we have a nice guideline, and that becomes policy. But I think what we're talking about here is much wider than you can create a nice guideline for, and I think we're not very good. So like some of the things that came up in our stakeholder group, like, what's the role of volunteering in mental health? And we were able to say, well, actually, we don't need to do research, and that there's loads of research, but let's review it for you. And we're not very good at that, reviewing the soft, I say soft, I shouldn't say soft, but the wide range of types of evidence and presenting or feeding it back to organisations. In health, we're only good at this one narrow way of creating guidelines. So I think, we are trying to do that, but it's not a wide activity really. I think there's more scope for that, rather than just repeating research, which we don't need to do.
Yes, and is this working in silence as well as anyone? Eventually you find out someone else has been working on the same project. And it's all about networking and sharing the information. Completely agree.
Yeah, Susan, I've just your previous point about the review. It's quite resource intensive as well to do even review of reviews and things like that. My question was very, very pragmatic, a practical one, because you're based at your institution. So when you had the stakeholder forum, did you have new stakeholders on your database to contact, or did you build on your existing ones? And my second question is the related question, is that the stakeholder forum is service users plus other wider groups, and did you have anybody from policy or public health kind of things that would be important from the findings perspective?
So I mean, I suppose I said earlier, I have another hat as a health and care research service. So we had quite a lot of contacts through organisations we've done collaborations for. And then in the School of Health at Essex, we've been trying to map all of our kind of stakeholder networks through that service, but other projects that academics do. So we've been trying to kind of collect it all together. So we have a lot of ways of reaching out, but also then it's kind of snowballing. So, we invite people who we know, but then they say, well, maybe not me, but maybe my colleague. And I think, because I think someone was saying earlier, people change their roles a lot. So you kind of have to just keep reaching out and ask people to snowball for you, because you can't always know the right person.
It's used that approach before, but I think for this one, because we are at another university and you're more close to the coastal regions where you've been working, it's like our plan is to build on what we have through our public involvement and research group at UH and all that. But they may not go as far as the coastal regions, so that was the reason for my question.
Yeah. What was the other question you had?
Sorry.
Was there another question?
No, I think they were
forgot.
related
Okay, I
questions.
answered it.
Thank you.
Do you have any other questions? Could I just ask for reflection? And we've still got 5 minutes, which we can go early. But I was quite interested in how co-production links up with this idea of no strings funding, because it seems to me that co-production is something that pretty much everybody is behind. That it's very difficult to do, but there are established mechanisms for doing it well. But it's very, very difficult to do that properly when the desired outcome is established from the outset. So I'm wondering how you work around that. Are there ways that you can work around that effectively that could be useful for other people?
So I guess from this project perspective, it was kind of bringing things like Nesta and Nest principles of co-production to the table. So things like asset-based approaches, looking at reciprocity, looking at like blurring those roles. So not just looking at a community member as a community member, but an actual activist in the project and changing that mindset around it, allowing them to be catalysts in the project. So allowing them to take the driver's seat, so to speak. And then also allowing them to be part of that solution making, so them leading and telling you, okay, I think we need to have a discussion now, or this is not going very well, or offering that feedback mechanism. The reasons that we fell down is the time essence, because it takes a long time to build a relationship, first of all, especially when you don't have a very trusted membership in the first place. And then the second thing would be, again, the allocated sort of the granted money side of things, that the voluntary care partners, they did offer extra time post contracted time, but there was only so much goodwill that we could rely. It's not fair for us to do that in that respect, and therefore any of the groups that were made, any of the friendships and networks that were built upon, went about some of their projects and continued on, and we get feedback in terms of like how well it's going, not in an evaluative manner, but more of a case of, oh, this happened and we've done this X event and this many people turned up, and I've kind of got the generic feedback from that element. In terms of it being completely co-produced, it's more co-designed and co-created, because they've come to the table, they've come to the drawing board, they've said that these are the issues that they want to tackle and the way they want to tackle it, but it's not essentially being produced together on the fact that the voluntary care partners still had to steer them, rather than it just being community led in that entirety. Sorry.
No, thank you. I mean, I noticed, Susan, that you didn't use the term co-produced deliberately, but you are trying to bring in elements of that project.
Yeah, I suppose I just think it's a tricky term, isn't it? Because it's in some ways it's tightly defined, and I don't want to claim to be doing something I'm not. But it's a helpful concept, I think. But yeah, I wouldn't claim to be doing that in this programme. No.
I think we are very much almost out of time, so unless anybody has a quick question, we will thank the speakers and allow you to go and get first in line for coffee. So thank you. This has been a really thoughtful, reflective, honest and pragmatic discussion that I really enjoyed. I hope everybody else has as well. And